We are honored and privileged to have our keynote speaker here, Professor Mariya MOOSAJEE. She's Professor of Molecular Ophthalmology and Consultant Ophthalmologist in Genetic Eye Disease, Head of the Genetic Departments at Moorfield Eye Hospital, London, UK. She's a first-class honors in Biochemistry and Molecular Genetics, Medicine, and Molecular Ophthalmology, all from Imperial College. She has over 39 international and national prizes for her research and 150 peer-reviewed scientific publications. She also is one of the most influential people in ophthalmology in the top 100 list. She's also the president of the UK Eye Genetics Group, and she's an avid clinician, scientist, researcher focused on disease mechanism and new therapies. I'd like to invite Professor Mariya for her talk. Thank you.
A bit short here. So good afternoon, everyone. Thank you, Jaspreet, for inviting me to give this lecture and everyone on the committee. So I'm just going to be giving you a brief overview about genetic eye disease, diagnostics and therapeutics. So the burden of genetic eye disease is vast. It affects 1 in 1,000 people. It accounts for 60% of blindness amongst infants worldwide, and is the leading cause of sight registration amongst children and working age adults in the UK and in the West. Over 500 genes have been identified and are known to affect all parts of the eye. It can be isolated, complex and syndromic, as we've just heard, and these conditions are lifelong and largely incurable, and there are still only a few treatments. So our big challenge in this field is diagnostics and therapeutics. The spectrum of genetic eye disease is vast. I divide it between ocular maldevelopment and then postnatal conditions. So ocular maldevelopment include the structural globe anomalies, microphthalmia, anophthalmia, ocular coloboma, congenital cataracts, primary congenital glaucomas, anterior segment dysgenesis, albinism, etc. And then you've got conditions where the eye is essentially normal, but there are degenerative processes that can occur in childhood or adult onset. And these include the corneal dystrophies, inherited retinal diseases, vitreoretinopathies, and optic neuropathies. And for some of these conditions, up to 90% of patients can exhibit systemic features. So definitely being a friend of the pediatrician is important, especially when you're seeing children with these conditions. So the importance of genetic testing. Patients and families want to know the cause of their condition. We know that it will guide prognosis when you have a family that come in and say, when is my child likely to lose their vision? What's the course of the disease going to be like? The more we do genetic testing, the more we can aggregate our cohorts, and we understand natural history of disease, and we can start to establish genotype-phenotype correlations, which we've already heard about in the first 2 talks. It helps clinicians identify other disease associations. So if a patient presents with bilateral anophthalmia and we find that they have a SOX2 mutation, they may have SOX2 anophthalmia syndrome, where they go on to develop hearing loss, seizures. And so we can assemble the correct multidisciplinary team so we can provide the best care and reduce any comorbidities. We can provide informed genetic counselling to patients. We can tell them how they inherited their condition and their risk of passing it on to future children. And concurrent with that, we can then provide correct family planning advice. So we can offer pre-implantation genetic diagnosis to a number of genetic conditions. This is a form of IVF, where you take the sperm and the eggs, you fertilize it in a dish, and when it's a ball of cells, you take a cell, you check to see if it's carrying the mutation, can only implant healthy embryos back into the womb. And we also have access now to non-invasive prenatal testing, which is where a mother can conceive naturally, and then at around 6 to 8 weeks, you can take a blood sample, isolate the fetal DNA, see if it's carrying the mutation, and then the family can decide whether they want to continue with the pregnancy. patients who have a genetic diagnosis can access treatments, whether that be gene therapies or drugs, and it ensures that they can access the research that pertains to their particular condition. So there is a multitude of clinical trials out there. They can get involved with research, they can enter into natural history studies, which again helps us. So which genetic eye diseases can we test for? Well, as long as we can rule out an environmental cause, pretty much anything that we suspect is genetic. We used to just go for bilateral conditions, but I would urge you to consider those unilateral conditions. We saw a nice case of upward gaze restriction in the first case, but there are other patients, and in this image here you've got a father that had a unilateral iris coloboma, and he had a son who had severe bilateral iris coloboma and microphthalmia. And so just remember, don't disregard those patients that present with unilateral phenotypes. Patients that have asymmetry and complex phenotypes are another group that we should be investigating. I mentioned if there's no clear environmental and acquired causes, and if the patient has any syndromic features. History is key. The onset of symptoms and signs noted down in chronological order, whether the patient has, for example, night blindness, then field loss, then central vision loss, systemic features including developmental delay, hearing defects, learning difficulties, polydactyly, kidney problems, and make sure you examine those patients. Ask them, were they born with an extra digit that may have been removed at the time of birth in the operating theatre, as you can see with this lady's hand here. Ask about their drug history, because there are certain drugs that can mimic certain inherited retinal diseases. Then go back to the birth history. Ask about whether it was a planned pregnancy, what was happening at the time of conception. Knowing that we see the first signs of the developing eye at day 21, a time when parents may not even know that they're pregnant, we need to know what was happening around those events. Whether this was IVF conception, miscarriages, if the mother had any prenatal infections, illnesses, and was taking any medications. And then the family history to ask about consanguinity, any other affected family members, noting down their phenotypes, and to make sure we note down their ethnicity, because we know that certain variants are more prevalent in certain populations, whereas they may be more benign in others. Now, as I mentioned, in the UK, we're very lucky. The gold standard there is whole genome sequencing, so we can sequence all 3 billion nucleotides and over 20,000 genes and their non-coding regions. We can screen known genes, but it allows us to interrogate novel genes in the research environment, and we tend to send parent-offspring trios as the gold standard. And this is increasing our diagnostic rates by 40%. So this is just a case, a 13-year-old Bangladeshi girl who has been wearing glasses for myopia since the age of 7. She developed cataracts at age 11. She has past medical history of learning difficulties, some delayed speech, asthma. Her parents are consanguineous, no other family history. And on examination, she has microcornea and these blue dot cataracts. Vision was 0.7 logMAR with normal pressure. So we applied a cataract panel to this patient, and the results was cerebrotendinous xanthomatosis, and we found homozygous pathogenic mutations in CYP27A1. Now, this condition is characterized by chronic diarrhea, childhood cholestasis, and failure to thrive in infancy. Things that are quite common and could be just go by unidentified. Later on, around the age of 13, she developed the cataracts. And if we hadn't have done genetic testing at this point, we would have missed this diagnosis. She would later go on to develop tendon xanthomas and neurological complications, including neuropsychosis. Now, there is a treatment for this, chenodeoxycholic acid. And if a patient starts this before the age of 25, it can halt symptoms. And if it started as early as her age, it can prevent those. But from our studies, we've shown that over the majority of patients do not get a diagnosis by 25, and therefore you cannot treat or reverse these conditions. So hence we must do genetic testing when we're presented with children with childhood cataracts, just because we have an 80% chance of getting a diagnosis. So case 2 is actually now a lady, 25-year-old, Caucasian, who had bilateral congenital ptosis. She had a frontalis swing age 2, and she continued her life. She was fine, but she was just about to get married and was concerned whether or not, if she was to start a family, would her child be born with this. So in her past medical history, it's nil. She's got normal menstruation, no consanguinity. She's got bilateral ptosis and epicanthus inversus on examination. Visions are fine. So we applied a structural eye disease panel, and we found that she had a heterozygous variant in FOXL2, which causes blepharophimosis, ptosis, and epicanthus inversus syndrome. This is a dominant condition, so she now has a 50% chance of passing this to her children. It's associated with premature ovarian failure, and this cannot be determined genetically. So in these ladies, we need to provide genetic counseling and careful discussion about family planning. And if we diagnosed her earlier, we would refer the patients to gynecology once they are 16, so that they can have a discussion about ovarian reserve and response assessment for fertility. So the final case is retina. I had an 11-month-old Caucasian mixed Italian-British boy referred to me. His parents noticed that from 4 months of age, he was not looking at their faces, not tracking. There was difficulty with his vision in dim light. He could not discriminate between yellow and blue toys, and he preferred staring at lights. No past medical history, and his vision was 0.9 logmar in both eyes. This was the fundus image that looked normal, but there was a lack of fundus autofluorescence. So with the lack of fundus autofluorescence, the staring at the light, we had a strong suspicion that this could be RPE65. We applied the retinal dystrophy panel, and that confirmed the diagnosis. And so this patient was eligible for voretigene and Apavovec, age 3. And 6 months after receiving the gene therapy, his vision improved from 0.9 to 0.5 logmar. But then after 6 months, his vision dropped to 1 logmar. So just to say that we now have the PERCEIVE study, which is the real-world experience of patients receiving these gene therapies, and it has an update of 103 patients undergoing this, and it showed that there was no significant change in best-corrected visual acuity, but there was an improvement in full stimulus threshold testing. 51% of patients experienced ocular treatment adverse events, and close to 13% of patients develop this chorioretinal atrophy in the area of the bleb. So this is just something that we need to be aware of when we are consenting our patients going forwards for gene therapy. So there are multiple therapeutic approaches out there now. There are those targeted towards the gene or the mutation. Gene therapies that are emerging and maybe close to approvement is RPGR, and we're just starting a dual AAV gene therapy for ABCA4, the commonest macular dystrophy that we see. There are gene therapy trials for CRISPR-Cas9 gene editing targeting CEP290, and RNA therapies using antisense oligonucleotides, again for CEP290, and a trial for USH2A, which causes Usher syndrome and non-syndromic RP with mutations in exon 13. And then there are trials targeted towards common disease pathways, drugs such as N-acetylcysteine, which is a high-dose antioxidant, which is in a phase 3 clinical trial for retinitis pigmentosa. Gene therapies, for example, rod-derived cone viability factor. So the principle of this is that your rods release this factor, and your cones uptake it, and it helps your cones uptake glucose to convert to energy so they can work effectively. And when your rods die off in RP, they don't release this, and so your cones starve to death. So if you re-deliver this back to any residual cones, they can uptake the glucose and maybe last a bit longer. And this is in an early phase 3 trial with a company called Sparing Vision. And then there are trials that are looking at delivering human retinal progenitor cells through subretinal injections to the back of the eye as a form of neuroprotection to support residual photoreceptors as opposed to actually converting into photoreceptors. And a company called J-Site is doing this trial and has completed a phase 2. We're waiting to see if they'll start phase 3 soon. So I'll just leave you with this website, www.gene.vision, which is a resource A to Z on genetic eye diseases. It's written for patients and for professionals, so the pages for patients is all in lay terms, and there is Google Translate attached to this, so you can get it in any language. It's helpful for you if you're sitting in clinic and you see a genetic result with a gene, you can look it up, and it's got the resources on all the trials and the background behind those trials and how to access that. So to conclude, please send your patients for genetic testing. I strongly feel that the inherited retinal disease field has done very well over the years, but some of the non-retinal conditions deserve an equal amount of genetic investigation. Molecular diagnostics can unlock the correct care that we can give for our patients, prognosis, access to research and treatments. There are multiple clinical trials underway, and we have entered the era where genomics and gene therapies will hopefully make a real difference to our patients with inherited eye diseases. So just to say thank you very much.
Thank you, Professor MOOSAJEE, for a brilliant presentation, and taking out time coming all the way from UK and enlightening us. No doubt, I mean, we've learned a lot, and thank you for everything. And we'd like to have your expert comments. As a keynote address, there are no questions.